Welcome to the deep dive. Today we're taking a closer look at transient tachypnoea of the newborn TTN.
Right.
It's that fairly common, usually pretty short-lived breathing issue some newborns get right at the start.
Mm-hmm.
Our goal here is simple. Give you a really clear, high-yield understanding of TTN for your revision. We'll hit all the key points.
Sounds good.
So if you need that concise but thorough breakdown, you are definitely in the right place. Let's dive in.
Okay, so definition first. TTN is, well, it's a self-limiting respiratory disorder. The main feature is rapid breathing, tachypnoea, starting soon after birth.
Self-limiting meaning it gets better on its own.
Exactly. And the key point, the reason it happens, is because there's a delay in clearing the fluid that was in the baby's lungs before birth, fetal lung fluid.
Okay, so that delay, what actually causes it? What's
Yeah.
the likely trigger?
Yeah, the main mechanism is just that the slow resorption of that lung fluid.
Okay.
Certain things make it more likely, like a cesarean section delivery, especially if mom didn't go into labor first. Also being born a bit preterm, or just general lung immaturity can play a role.
Gotcha. And are there specific sort of risk factors we should really flag up?
Mm-hmm.
Maybe an easy way to remember them?
There is, actually. A good mnemonic is MACMA. Think of it like,
Yeah.
well, MACMA.
MACMA.
Okay, so M is for male gender. A for asthma, that's maternal asthma. C for cesarean section delivery, we just mentioned that.
Right. CSUS.
And then MA is for macrosomia, so a larger baby, and the other MA is for maternal diabetes.
Okay, MACMA. Male, asthma, maternal, C-section, macrosomia, maternal diabetes. That C-section link sounds quite important.
It is. The thinking is that the hormonal changes and, the physical squeeze during a vaginal birth really help push that fluid out. You miss some of that with a C-section, especially elective ones.
Makes sense. So this extra fluid is sitting there.
Yeah.
What does that actually do to the baby's breathing mechanics?
Well, what happens is the fluid makes the lungs a bit stiffer, less compliant, so decreased lung compliance.
Harder to inflate.
Exactly, like trying to blow up a balloon that's a bit tough. This means the baby has to work harder just to take each breath.
Okay.
And that increased work of breathing leads straight to the tachypnoea, the rapid breathing, and sometimes those other signs like grunting or flaring. Mild to moderate distress, usually.
So you see a baby breathing fast, maybe grunting. What else might be going on? What are the main things to rule out?
Good question. You always need to think about the differential diagnosis. Key ones are respiratory distress syndrome, or RDS.
That's the surfactant issue, more in preemies.
Primarily, yes. Then there's pneumonia, an infection in the lungs, and also meconium aspiration syndrome, where the baby breathes in meconium around the time of birth.
Right. Important to keep those in mind.
Definitely.
And how common is TTN itself? Are we talking rare or?
No, it's relatively common. In the UK, it affects maybe 1 to 2% of term infants.
1 to 2%. Okay.
But like we said, the incidence is higher in babies born via C-section and those whose mothers have diabetes. That birth canal journey really seems to help.
Got it. So let's picture a baby with TTN. What are the classic signs we'd observe?
The absolute hallmark is the rapid breathing, the tachypnoea, often over 60 breaths per minute.
Okay.
You might also hear grunting, that noise they make, exhaling against a partially closed glottis. You might see nasal flaring, trying to get more air in. And maybe some pulling in of the chest muscles. That's the respiratory distress.
But usually mild to moderate, you said.
Usually, yes. And a really crucial point, significant cyanosis, that bluish color, is uncommon. That's quite helpful clinically.
And what about imaging? What would a chest x-ray show?
The chest x-ray can be quite characteristic. You often see lung hyperinflation. The lungs look a bit bigger than usual.
Okay.
And the classic sign is fluid in the horizontal fissure, particularly on the right side. Sometimes people describe it as a wet silhouette around the heart or streaky markings. Think of it as a visible stripe of leftover fluid.
Right, that stripe of fluid. Good tip. So if we suspect TTN based on the clinical picture, what investigations are essential?
Well, the chest x-ray is pretty much essential, partly to confirm the signs we just talked about, but also importantly to rule out those other conditions, like RDS or pneumonia.
Makes sense. Anything else? Blood tests.
Yes, we usually do blood tests. An arterial blood gas, or sometimes a capillary gas, is important. It tells us about their oxygen levels, carbon dioxide levels, and acid balance. Helps assess how severe the respiratory compromise is.
Okay, so we've got the signs, maybe the x-ray findings, we've done the gas, we think it's TTN. What's the management strategy?
The good news is management is mainly supportive. Observation is absolutely key.
Watching and waiting.
Pretty much. Because it's self-limiting, most babies improve spontaneously within, say, 48 to 72 hours, sometimes even quicker, maybe 24 hours.
Oh, okay.
During that time, they might need some supplemental oxygen, just enough to keep their oxygen saturations in the normal range.
And if they're working quite hard?
If they have significant work of breathing or need more oxygen, then CPAP, continuous positive airway pressure, can be really helpful. It just provides a bit of pressure to help keep the airways open and makes breathing easier.
CPAP. Okay. And monitoring, obviously.
Oh, definitely. Continuous monitoring of heart rate, respiratory rate, oxygen saturation, vital signs are crucial.
And looking ahead, what's the usual outcome? How do these babies do?
The prognosis is generally excellent, really, really good. With that supportive care, it typically resolves completely within a few days.
Any long-term effects?
Usually none. Most babies recover fully with no lingering problems.
That's reassuring. Are there any potential complications at all, even if rare?
Complications are definitely rare, which is great. But, in any situation where a newborn has respiratory issues, there are small risks. Very
Yeah.
occasionally, you could see something like a pneumothorax where air leaks out of the lung.
Okay.
Or in severe, prolonged cases, you might worry about progression to respiratory failure or potentially a superimposed infection, though that's uncommon with simple TTN.
But the main message is early recognition and supportive care usually prevent these.
Absolutely. The vast majority do extremely well with just that supportive approach.
So wrapping it up, the big picture for TTN is it's usually a temporary breathing hiccup in newborns, often linked to how they were born, and it gets better with some basic support.
That's a perfect summary. And maybe a final thought for you to consider. Think about why those risk factors, C-section, maternal diabetes, lead to delayed fluid clearance. What does that tell us about that incredible physiological shift from life inside the womb to breathing air? It's quite amazing, really.
It really is. Some excellent points there. For more high-yield revision just like this, make sure you check out PassThemSRA.com and FreeMSRA.com. Thanks for joining us for this deep dive.